Thank you very much for a kind introduction. Now I will present briefly a newborn screening program in Slovenia, its past developments, its present status, and our future plans. Also a pathway in the last decade from a relatively modest program to one of the, I would say, most modern programs existing. So the newborn screening system in Slovenia is actually comprised of one central MBS center located in University Medical Center Ljubljana and 4 additional maternity hospitals which are dispersed through Slovenia. In general, Slovenia has a population of 2 million people and live births are 9.5 per 1,000 of population. In 2020, we had 18,363 births. Newborn screening in Slovenia actually started in the year 1979 with the introduction of screening for phenylketonuria, and 2 years later, congenital hypothyroidism screening followed. In the next year, also some other screening, non-biochemical screening programs were introduced, like screening for hearing impairment, ultrasound of hips, and some years later also screening for optic media translucency and saturation in limbs. But the first biochemical expansion of newborn screening happened only in 2018 with the introduction of 17 other inborn errors of metabolism. The second expansion is planned in the year 2022 with introduction of cystic fibrosis screening, congenital adrenal hyperplasia screening, inborn errors of immunity screening, and spinal muscular atrophy screening. And we also plan regular next expansions every 3 to 5 years. When we planned the first expansion in 2018, we first prepared a pilot study, which was also focusing on next generation sequencing as a follow-up test in an expanded newborn screening program. And after the expansion of newborn screening, we also prepared a quality control study, including the first 15,000 screened newborns, which showed that 2% of them had either borderline or positive screening test results. All the facilities, including maternity hospitals and the central screening facilities, are connected into common IT network, which enables ordering tests, which also enable results authorizations and results distributions to all the maternity hospital who order actually the test. We also introduced barcodes on the DBS cards to enable a good traceability of DBS cards and also enable retrieval of information of individual patients, which is especially important when we urgently need this basic information about the patient. So the flow chart is as follows. If the result is borderline, we repeat the analysis from new DBS. If it's positive, the child is directly referred for further clinical and laboratory checkup at the University Children's Hospital Ljubljana. If the repeated DBS sample is positive or for the second time borderline, also this group is referred to the University Children's Hospital Ljubljana, where we frequently proceed with the NGS testing and in some cases also with further enzyme activity analysis. The samples are in these cases sent abroad. We have an in-house gene NGS panel of 72 genes for confirmatory testing for newborn screening. It is performed in all screening positive cases and frequently also if the results are unclear. Pending is the development of DNA isolation method from DBS card, and we plan also to introduce real-time PCR for spinal muscular atrophy and immunodeficiencies screening next year. So this is our in-house gene panel comprised of 72 different genes. And as mentioned, next expansion will happen next year as planned. We will introduce spinal muscular atrophy newborn screening and selected inborn errors of immunity newborn screening. Those will base on real-time PCR. We will also introduce cystic fibrosis newborn screening and congenital adrenal hyperplasia newborn screening based on immunochemistry methods. If we put newborn screening into a broader perspective, out of over 7,000 different rare diseases, only around 50 are being currently screened by best newborn screening programs. So there is actually a huge room for further expansions in the future. To conclude, in Slovenia until 2018, we screened only for 2 diseases biochemically. From 2018, we screened for 90 diseases. And from 2022, we plan to be screening for over 40 diseases. What is important is to engage all the stakeholders into the MBS ecosystem at both the national or regional level, to include the common IT platform and also that they are connected at the laboratory and clinical levels. With currently screening for less than 1% of rare diseases, each newborn screening center should be or should expect the further expansions of newborn screening. And of course, in future, there will be an increasing role of genetic testing, which is now mostly confirmatory. Thank you for attention. And as a next speaker, I would like to introduce Professor Stefan Kulker from the Heidelberg University.